The term posture is used to describe the relationships among various parts of the body, their anatomical arrangement, and how they are affected by intrinsic and extrinsic factors.
In this lecture, we will discuss normal body posture and how it can be assessed.
In part 1, we'll review how modern human posture evolved. In part 2, we'll delve into the rationale of postural assessment. In part 3, we'll finish with an outline of a postural assessment rubric or series of steps that you can follow when you begin to assess posture yourself.
Knowledge of how human posture has evolved can provide us with the sound theoretical foundation for its evaluation.
The adaptations that predicated our ability to assume a position of upright stance on two legs or bipedalism provide valuable insights into what activities we are and are not suited towards.
The ability to stand and walk on 2 feet is widely recognized as the first major transformation that led to the evolution of the human genus.
Upright bipedalism was the spark that set the human lineage off on a separate evolutionary path from other apes.
Charles Darwin first suggested this idea in 1871.
Lacking any fossil record, Darwin reasoned that the earliest human ancestors evolved from apes. By becoming upright, they freed their hands from quadrupedal locomotion.
This allowed them to make and use tools. This then favoured the evolution of larger brains, language, and other distinctive human features.
Today we are so thoroughly adapted to being habitually bipedal, we rarely give our unusual way of standing, walking and running much thought. Therefore, learning about how our early ancestors became adapted to being upright is a good starting point for assessing normal posture. As a first step, let's compare our anatomy with that of our chimpanzee cousins.
First, let's review our spine. Like other quadrupeds, apes have spines that curve gently in the sagittal plane, so when they stand upright, their trunks naturally tilt forward. As a result, the ape's torso is positioned unstably in front of its hips. So to maintain this position, they must contract the muscles at the posterior aspect of their torso and hips.
This is inefficient. In contrast, humans have an S-shaped spine. We have 2 pairs of curves.
The lower lumbar curve is made possible by having more lumbar vertebrae.
Apes usually have 3 or 4, whereas humans usually have 5 lumbar vertebrae.
Several of these vertebrae are wedge-shaped, the result of which is that the spine is aligned above the pelvis. The curvatures at the thoracic and cervical spines create another, gentler curve at the top of the spine, which orients the head above the hips.
Yet more crucial adaptations for upright locomotion are at the other end of the body, in the foot.
Walking humans usually land first on the heel and then, as the rest of the foot makes contact with the ground, we stiffen the foot's arch, enabling us to push the body upward and forward at the end of stance, mostly with the big toe.
We'll cover human locomotion in greater detail in a later lecture, but for now, consider the following important adaptations of foot posture.
The shape of the human arch is created by the shapes of the foot's bones, as well as by many ligaments and muscles that secure those bones in place. The surfaces of the joints between the toes and the rest of the foot also enable us to bend our toes at an extreme angle.
This means we can push off during gait, improving efficiency.
Apes' feet lack an arch, preventing them from pushing off against a stiffened foot, and their toes are unable to extend as much as humans. Moving up to the hips, we can see the large, broad bone that forms the upper part of the pelvis, the ilium, is tall and faces backwards in apes. But this part of the hip is short and faces sideways in humans.
This sideways orientation is a crucial adaptation for bipedalism because it allows the muscles on the side of the hips, the small gluteals, to stabilize the upper body over each leg during unilateral stance.
Standing back from the details, the overall picture that emerges is that our posture has evolved in response to the changing demands of our environment and the activities and behaviours of our distant evolutionary ancestors to produce the form that we recognise today.
The practical upshot is that when we perform activities that our posture is not adapted for, discomfort, dysfunction, pain or injury may result. Let me give you an example.
Consider the effect of all those hours of sitting that the typical 21st century human does on a typical day. I'm simplifying matters here, but let me outline a potential sequence of knock-on effects to the blank canvas of good posture. When you sit in a standard chair, your hips and knees are flexed at right angles, a position which shortens the hip flexor muscles that cross the front of your hips. Over time, your hip flexors become tight. Tightened hip flexors can tilt the pelvis forward, leading to an exaggerated lumbar curve. Your hamstring muscles along the back of your thigh may then contract or tighten to counter this curvature, tilting your pelvis backwards, leading to a flat back posture, and this is often associated with a change further up, whereby the shoulders become rounded and hunch forward.
Each of these changes, a pronounced lumbar curve, increased thoracic kyphosis or rounded shoulders, can, but not always, be associated with the development of discomfort, dysfunction, pain, or injury. Let me give you another example.
If you wear high heels all the time, your calves may become tight because they are always in a shortened position. To accommodate the resultant decrease in ankle range of motion, your knees and hips have to increase their range, and this may occur not only in the sagittal plane, but also in the frontal plane. So individuals with tight calves may display greater knee valgus when trying to lower their center of mass, a position that is not conducive to optimally recruiting the knee musculature, and injury may result.
I'll reiterate that these are gross simplifications, but they demonstrate how an understanding of how our posture evolved can underpin our comprehension of what we are looking at when we are conducting an evaluation. In the next part, we'll delve into why we would actually want to assess posture and how it can inform our choice of intervention.
The postures we assume provide clues to not only the condition of our bodies, like prior injuries or pathologies, both old and new, and our age, but also how we feel about ourselves, our confidence, how much energy we have, how enthusiastic we feel, or whether we feel tense or relaxed.
The difficulty, however, is that while there are general signs of these physical and emotional profiles, they can be different for different people. You must always remember that when you are performing your postural assessment, there are a web of factors that interact and manifest in what you assess.
Therefore, making a definitive conclusion based on or about any physical or emotional condition identified through postural assessment alone can be problematic.
Postural assessment is simply a tool in the toolbox of the healthcare professional, coach, or trainer. Be very careful not to over-extrapolate. As therapists, coaches, or trainers, there are two fundamental assumptions underpinning our evaluation or our efforts to evaluate our patients. This is no different for a postural assessment.
The first assumption is that we are actually measuring what we are purporting to measure when we measure it. This is called the validity of a measure.
This may seem a little convoluted, but it is actually very simple. When you measure distance, you might use a ruler or a distance wheel. Or if you are measuring time, you might use a stopwatch. These are valid measures of distance and time, respectively. However, let's say you didn't have a distance wheel and decided to count the number of steps between 2 points. Let's say you assume that 2 steps is 1 meter. The validity of that measure of 1 meter is probably not perfect. So when you decided that the distance from point A to point B is 100 meters, based on the number of steps between the 2 points, the validity of your outcome measure, steps, may undermine the accuracy of the measurement.
Building on this example of counting steps, the second assumption is that when we repeat this measurement, either at a later date or if someone else does it, or if there is a change in the distance between point A and point B, that the result would be the same. This is known as reliability.
Reliability is basically the consistency of the measure. Instead of just measuring the distance between point A and point B once, we may measure it 10 times. If we were using a distance wheel, we would probably get close to 100 meters each time. However, if we were counting or measuring using our count of the number of steps between the 2 points, or if we got someone else to do it, we would probably have more variability in the result. The distance wheel is more reliable than counting steps.
Coming back to our evaluation, we want our measures to be valid and reliable. With distance, we could be reasonably confident that our measurement with a distance wheel or a ruler is both valid and reliable.
However, you're never going to get perfect validity or reliability when measuring something like posture. It's just too hard to measure. There are too many moving parts. That's not to say we can't try, but we must recognise these fundamental principles when doing so.
So, assuming that when we measure posture, that we are doing so with an acceptable level of validity and reliability, why do it? Many professionals would argue that you should perform a postural assessment on all clients presenting for sports massage, physiotherapy, or osteopathy treatments. This is so that you can monitor the effectiveness of a treatment on a specific body segment, prevent the development of future injury, or optimize athlete performance, for example.
In some cases, a postural assessment is warranted, but it must be performed with care. For example, you may want to assess an elderly person who has suddenly become unbalanced when using a regular walking aid. In this case, you need to assess the patient standing with the aid, yet you must also ensure safety. Similar caution needs to be taken when assessing a client with a recent injury. With such patients, weight bearing or a change in posture may aggravate their discomfort.
However, for the purposes of this module, we will be focusing on the postural assessment of individuals with no disease or impairment.
In the next part, I'll outline a series of steps for postural assessment and discuss normal human posture. Posture can be assessed in a variety of ways, using different equipment, viewing perspectives, and scoring systems. We won't go into detail about all the different ways you can assess posture. Rather, I'm going to outline a series of steps that you can follow to do so.
As we discussed in the last part, this series of steps, or this rubric, should increase the likelihood that your assessment of posture is both valid and reliable.
To help you remember, this rubric can be broken down into 3 components: position, plane, and part.
In other words, what is the patient's position? Are they sitting or standing? Are they static, or are they performing some kind of movement task? Plane refers to the examiner's perspective. Are you viewing the individual in a sagittal, frontal, or transverse plane? Finally, part refers to the specific body segment under evaluation.
Most postural assessment paradigms break the body into general parts, like the head, neck, shoulders, thoracic spine, lumbar spine, pelvis, hips, knees, ankles, and feet. Obviously, all of these parts are interconnected and interrelated, but it makes things easier if we can evaluate them as individual components of a larger whole. Taking this rubric, we can begin to employ our knowledge of anatomical terminology to describe posture in terms of position, plane, and part, validly and reliably.
The illustration shows a subject standing upright. We can assess posture in the sagittal plane from this perspective. With regards to part, let's begin with the head. We could say that the head is in a neutral position, not tilted forward or back, that the cervical spine has a normal curve, in other words, that it is convex anteriorly. The thoracic spine is slightly convex posteriorly, as we would expect, and the lumbar spine is slightly convex anteriorly too, and it has a normal curve.
Commonly observed abnormalities of the thoracic and lumbar spine include an increased kyphosis and lordosis, respectively, where those convex curves become more pronounced.
Back to our assessment. The pelvis is in a neutral position, it's not rotated too far forward or backward, and this is based on the position of the anterior superior iliac spine, which I would expect to be slightly inferior in the sagittal plane to the posterior superior iliac spine, and in the same vertical plane as the pubic symphysis. The hips are in a neutral position, neither flexed nor extended, as are the ankles.
Viewing the subject in the same position from a different perspective, specifically from behind, allows us to assess posture in the frontal plane.
The head is in a neutral position, not flexed nor rotated to one side. The shoulders are not elevated or depressed, and they are symmetrical. The scapulae are symmetrical too, in a neutral position. Their medial borders are parallel to the spine and positioned approximately 3 inches from the midline of the thorax, or spine. We observe that there is no curve in the frontal plane at the cervical, thoracic, or lumbar spine. In other words, there is no evident scoliosis of the spine, and that the pelvis is level using the posterior superior iliac spines as landmarks. The lower extremities are neutral, there is no valgus or varus at the hips or knees, and the subtalar joint is in a neutral position, neither inverted nor everted. The feet are parallel, or there may be slight out-toeing.
You can see the relative subjectivity of this process and the innumerable ways that posture could be described. While this illustration is fairly simple, it is not uncommon for two therapists to describe different findings based on an evaluation of posture, or for the same therapist to describe the same presentation differently with repetition. The reality is that optimal posture is very difficult to assert, and that the reliability of postural assessment using a visual assessment alone, even when following a rubric like position, plane and part, is not always reliable or valid. That's not to say we shouldn't do it, but we need to recognise these limitations, as I said previously.
The important thing to take from this lecture is the systematic approach to assessment and the use of anatomical terminology to adequately describe observed reality. Such systems improve reliability and validity, as discussed in Part 2.
That concludes this lecture introducing you to the principles of postural assessment.
In this lecture, we briefly discussed the evolutionary biology of normal human posture and considered why you would want to assess posture. We highlighted the importance of validity and reliability when conducting any evaluation of posture,
and finished with a basic rubric for postural assessment. This lecture was prepared for students enrolled in the UCD School of Public Health, Physiotherapy and Sports Science. Images were taken from the Complete Anatomy software prepared by 3D4 Medical.